Assalamu alaikum حضور الكرام. Excellencies, distinguished guests, ladies and gentlemen. First of all, I would like to express my sincere appreciation on behalf of our panel members to the Iraqi Cultural Center, particularly to Dr. Abdurrahman Diab for hosting and organizing this session on harmonizing Iraqi and Kurdish healthcare reform efforts with focus on rebuilding medical ethics and clinical research. Our appreciation also goes to the healthcare professionals globally who have responded and provided comments in favor of this long-due event. Currently, as we all know, the healthcare system in Iraq and its Kurdistan region is in need of an upgrade through reforming the foundations such as medical ethics and clinical research to inspire better outcomes, trust and experiences. We would like to make it clear that this is a non-political session, and the aim of today is that together as a team we collectively work together to provide a better nation's healthcare system. We appreciate that not all groups and associations have been represented today on the panel, but it is important that we work past this and participate to plant the seed of reform. We know that the delivery of healthcare is different between Iraq and its Kurdistan region, and we feel that it is time to highlight the situation and propose solutions. The panel's aim tonight is to diagnose problems, agree a treatment plan with your input, and ensure that the prescription is adhered to. It's our sincere hope that this session will provide an opportunity for all participants to exchange different views and to share experiences. We also hope that each of you will take active part in the discussion and establish personal ties between participants. We are confident that this session will help facilitate the preparatory strategic reform plans. I would like to introduce our panel members that are present today who will lead the discussion this evening. Dr. Faryad Hiwazi, who is a consultant hematologist and a chairman of support committee for the higher education in Kurdistan. He also is a regular visitor to the region and supports higher education and provides lectures to postgraduates, doctors. We have Dr. Faryal Ahmed, who is a consultant microbiologist and a former president of the Iraqi Medical Association in UK and current treasurer of the IMA UK. Dr. Faryad is also an external examiner for 10 years for the final year medical students in Iraq. We have Dr. Sumit Abi Gunaskara, who is a consultant nephrologist working at one of the world's best burns and plastic hospitals. He has a wealth of experience and has an interest in ethical delivery of care in developing countries. We have Mr. Laween Atroshi, who is a former British central government official who worked for the UK Department of Health within high-profile clinical governance and strategy team and performer list regulation and responsible officer. He currently works as Chief of R&D Officer in one of the world's best burns and plastic hospitals. He's also responsible for the clinical research. He's also a patron of an independent charity, Wisdom Humanitarian Academic Movement. And finally, we have Ms. Mary Atkins, who's a Chairman Institute of Fundraising in East Anglia region. She's an experienced fundraiser and a grant assessor to the EU national, regional and local level, contributing towards 50 billion raised by the fundraisers throughout the UK to support big society. She has worked for and with the trustees, staff, communities and volunteers to create a community of giving, providing environmental, social, economic benefits for all national and local strategic plans in the UK. I would like to ask Dr. Kawa Amin, who is a registrar in care of elderly in Broomfield Hospital, to start, also starting a consultation job in October this year. He'll be presenting a small presentation of slideshows on ethics and diversity, which can be used as a framework for this evening's discussion. Thank you.
Thank you very much for inviting me for this. as I mentioned, I have to thank everybody here to give this opportunity. And I'll present a very small presentation just to make it as a frame of this meeting, and also to make it as a think tank meeting here in this hall. I think the most important part of, in my opinion, for clinical research and ethics is about equality and diversity within any research or any medical or health community. So what's the clinical research? Why it is important for us to have it? Well, clinical research is essential to enable us to provide the best health care to the patient or the people. Evidence-based medicine or practice are a process of systematic review of that studies and research to find what's the optimum, what's the best for all patients. However, evidence-based medicine or practice should recognize many aspects of healthcare depend on the individual and community factors, and that's such as equality and the value of life. Therefore, it is really important to connect any research or study, evidence-based medicine or practice to the social ethics. Well, the very brief definition of this equality and diversity. Well, equality is essentially creating a fair society, while diversity is accepting all the values and differences in that society or in that community, regardless of their any differences. But in Iraq as a general, and specifically in Kurdistan, we have too many hurdles. And I think that's not unique for that community. It's everywhere, but it's about how to overcome that hurdles and obstacles. We have troubles of differences in races and ethnics, belief, religion, sect, education background, even gender, even accent. The people speaking different dialect, they may have difficulty in engaging in research in different regions. Language, location or geographical location of the people, the researcher and the patient. And many researchers back in Kurdistan, they have difficulty in recruiting patients just because they are restricted in the geographical area, and that can be creating troubles. Now the consequence is not good. I mean, we have to overcome that hurdle, otherwise you get to be a vicious circle. It's going to be a blaming culture rather than just building forward and developing and evolving that system. But to overcome these hurdles, there are a few uncertainties that we should highlight, and I hope it will get to be highlighted in this meeting. Our current decision problems are based on 3 factors, in my opinion. We need more information, and that's very important. Otherwise, we cannot locate the services, and we don't know where we should put our money. But how can we get that hurdle? Well, we need environmental research. We need survey, and then we can build the forecasting. It's really crucial to have the coordination, and that is of a certainty of relating decision. We need to be connected with the decision maker people for the local area, planning and also developing. Also, we need to have a very clear objective. It's really important for whoever is coming. Sorry, this slide is not functioning properly, but I'll just continue here. It's about uncertainty of value. We need to set up our aim, our objective, or what's our priority, and then we can allocate service or resources appropriately. As I mentioned in the very beginning here, I think that this meeting should be as a think tank. With help of our panel, of delegate panel here, we can reach a decision and recommendation. And thank you very much.
Thank you, Dr. Amin, for that excellent presentation. We will freeze on the last slide, and I'll leave it to my panel members so they can refer to the certainty questions. And I would like to ask Mr. Laween Atroshi to give us a brief overview of tonight's presentation.
Hi, hello everyone. Apologize for my voice, I have a bad cold. Everybody's here for a reason today, and that reason is we want to improve patient health care in Iraq and its Kurdistan region. And through that passion, I think that's what's made us come in this cold weather with all these train problems and all the traffic. We still managed to come. The reason that we decided to have this event today, and the reason why we had the title, Harmonising Iraqi and Kurdish Healthcare, is because, and a lot of people called in to ask why we had that title, which is why I will address it. There are two different systems at the moment. There is a system that's happening in Iraq, and there's a system that's happening in Kurdistan region because of various reasons. And I think that we thought it would be quite important to harmonise the reform efforts so that no region falls back and no patient falls back from getting the best possible care. And I think, and we all think, I think I'm right to say, is that we need to build the foundation. And the foundation is through medical ethics and clinical research. And I think that's what we're going to touch on tonight. And we plan to make a set of recommendations which we will present to all the ministries and all the governments and all the NGOs and all the associations, and hope that they'll take it on board. But we don't want to do it alone. We want to do it with the audience input. You don't have to be a doctor, you don't have to be a healthcare professional. You could give us your experience as a patient, and we will take that on board, and we will fight for that cause to ensure that in Iraq and its Kurdistan region, we have a patient-centered healthcare system. Thank you.
I would like to ask Dr. Frial Ahmed to give us an insight. Since she's a regular visitor to Iraq, can you please give us an overview of what you've observed and about the healthcare system in Iraq? Thank you.
Okay, thank you very much. Really, my brief talk is going to be about my observation on the health system in Iraq. The system is mainly based on family care approach, but in spite of that, the funding for health goes mainly to the secondary and tertiary health facilities. Health strategies are very weak, focusing mainly on clinical services rather than on strengthening public health issues and problems. Obviously, there are issues like obesity, smoking, and other health, public health issues, as well as infectious disease issues with their problems. As well as that, health finances is also very weak, so there isn't enough money to support all these initiatives. The health system, which is government-led system, is like we call it the NHS. In addition to that, there is growing private hospitals and private system clinics which provide health care without regulation. So it's not regulated or formalized. The health training in Iraq actually doesn't exist, or it's very, very low. Over the last, in spite of all, so far I have been negative, but over the last year there has been a government signed a memorandum of understanding between Iraqi government and Hallam University of Sheffield. And that is to train nurses, doctors, as well as technicians and other workers in the hospital. As well as that, they also have so far delivered 3 sessions of training doctors and senior physicians, as well as managers, who come to the UK and spend sometimes with the people concerned, and they were giving lectures and strengthening their understanding. As well as they are offering courses, mainly training for scientists, giving the master degree in various topics. This is all on the government expenses. Okay. The training has been done on a sort of not on official basis or continuous basis. You know, some doctors, they feel they want to do some lectures or seeing patients. They go to Iraq or they go to Kurdistan region. They do that, but it hasn't been something which is very firm and also continuous to give a stable training to all staff. For example, the Iraqi Medical Association started having video conferencing with the medical city in Baghdad, where they were discussing difficult cases from there, which with the specialists over here, and it was a very great success. I wish they will continue doing that every now and then. My observation on pathology laboratories delivery has been really the whole path system working in a suboptimal manner. I think I could say that in Kurdistan as well as in Iraq, but maybe a little bit better level in medical city. But you know, I don't think they have reached to a good standard that we see in this country. As far as the staffing of laboratories, there have been no strategy of you know, how many of the graduates to be appointed at each year, or if there is any capacity, or is there any place for them. No, they get graduation and they are appointed to this hospital or that hospital lab, and you see them wearing a white coat and, you know, talking and in the corridors. They have nothing to do, really. You know, it's very, very sad scenery to see that. As well as the equipment, you know, sometimes you find no basic equipment in these laboratories, very, very basic. And actually, there is no quality control and no quality assurance. As well as there is no health and safety policy or awareness of that, you know, including hand washing, drinking and smoking, or not smoking, drinking and eating in the laboratory and things like that, hand washing and glove policy. Actually, I just want to amaze you a little bit that in some of the laboratories, the staff who do some technique on the bench, they wear the gloves in the morning and they do the work and they go and write. Usually it's still paper procedures, it's not computerized. They write and they contaminate the pens and books and things like that, and the table, and they finish that. They might have a tea or coffee. While they are wearing the glove, they go on the bench and they do the work until they finish work. They never actually change the glove and wash their hands. It's just an example on what goes on there. Sensitivity testing is really very suboptimal. They don't have controls to control the this is my specialty, that's why I'm concentrating on that. And also there is no TB culture in the whole of Kurdistan. If they culture some TB from patients, they might send the odd culture to Baghdad for sensitivity testing. The other topic which it's also a topic of mine which I love is infection control. There is no concept of infection control in Kurdistan at all. They have just started thinking about it. And in Baghdad as well, I think the level is slightly better, but it's still suboptimal. They started to think about it, to adopt some policies and training to people, but they need really the whole setup to start from scratch and deliver a very good infection control system to the hospitals and in the community. Obviously, all the hospitals are old. The fabric of the hospital needs to be upgraded before you could actually wash the walls, clean the surfaces and things like that. So all this needs to be done. Ventilation, there's no ventilation, obviously, in theaters, nothing like that. So all this has to come as a parcel for infection control in Iraqi hospitals. Thank you very much.
just add the comment before, just one second. Just to add, the reason why, I mean, this is about the healthcare of Iraq and Kurdistan region. However, I think for the purpose of tonight, I think given the security issues that happen in Iraq, it might be best to use perhaps a hospital or in the Kurdistan region as a pilot for this reform strategy that will come up together tonight, and also roll it over to the rest of Iraq, just so that you're aware as in why Doctora is giving examples about Kurdistan and about Iraq, because the security situation in Iraq is very dangerous, which is very hard for doctors to go to mainland Iraq and provide medical care. However, that's not to say that we won't discuss the challenges that exist in Iraq, and also we won't, we will ensure that they also get a treatment plan as well. Thank you.
Thank you, Mr. Laween. Can Dr. Hiwazi also give us his observation of what he's seeing in hematology in his field?
Yeah, first of all, I have to thank Laween for arranging this meeting, and also to update you about what is happening in the medical business. And my experience really mainly concentrates on Erbil or Hawler, because we were there just we came back this last weekend. We were there about 4 weeks. And unfortunately, it is, my talk will be quite critical of what is going on. And to me, medicine is now a business there. And all the concentration from the doctors, from auxiliary staff, and from politicians is just how to make use of medicine to get money. And there is, of course, a background for that, according to me, and I will quite be happy with my colleagues if don't agree with me and to have a different explanation. Because medical ethics is very, very poor. The doctors, consultants, as they told me, they see them in what is called NHS hospitals. And maybe the background for that, according to my theory, in the early 70s, 80s, and when there was a war between Peshmerga and the Iraqi government, of course, a lot of Kurdish staff, doctors and medical staff, they were assisting Peshmergas illegally, sending them drugs, instruments, or treating Peshmergas in the hospitals without knowledge of the government. So that was, according to us, it was a patriotism. Probably if I was there, I was doing the same thing again. But later on, things changed. Government not there anymore, and it was under their control. But the doctors were attending hospitals without any salaries. There was no money, and so no drugs, no facilities. And then some NGOs were involved in it, taking some X-ray films, drugs, laboratory reagents, and because the doctors were there with no salaries, so they're doing whatever they wanted. They treated their own relatives or the staff. They were doing the investigation for the people they knew, because the government has got no authority on them because they were not paying them salaries. I've been there officially, maybe seen by myself. Minister tells them, keep those films for the officials, those reagents in the lab for officials when they come, and those drugs on the special side for us. And then things changed. We became very rich, a lot of money, our own government, but I think that mentality is still there. So still they don't behave more or less the same way. They say it is patriotism if they don't go to the hospital, if they leave early, if they don't care for the patients. So a lot of mismanagement from that point of view. At the same time, there is a lot of conflict of interest between the NHS and their private work. Because you see people very high in Kurdish politics, they have got their own hospitals. You see people very high in politics, they have got their own laboratories and X-ray facilities. And they have got their own hospitals. So I wonder how they can, at the same time, the consultants in the hospitals, They have got the private clinic and they have the private, they work in NHS hospital and they make use of NHS hospital to run their own private clinics. And the people, the X-ray people or the laboratory pathology people, because of their own X-ray facilities or their own labs, they don't encourage to have good machines in the hospitals. Or even if the machine is broken, they don't report it to be repaired. And even in pathology, you see they have got good machines. You ask them, oh, it's not working because we have no reagents. Or the machine is not working. They will phone the company, they don't come. I think all these are excuses. At the same time, you see in our own television stations, programs criticizing the NHS hospital. They visit the hospital, they show the people the weak points, the doctor is not there, the patient are complaining. So I get the conclusion that although they don't say it openly, but the KRG encourages privatization of the medical services because they criticize their own hospitals, so they encourage people to go to the private hospitals. At the same time, the private hospitals, a lot of them run by the politicians. And also there are agencies in every town collecting patients to go to Tehran, to Ankara, to Istanbul, to Beirut. They collect them just like, with my full respect, just like sheep. And all this is becoming worse and worse, and people is starting taking us as normal. It should be like this, which is to me, it is quite difficult. Same time, you see, there is no any progress in education. That on Sunday, I was meeting with the health director of Erbil. We were talking about the infection control, and they said, okay, we'll arrange a meeting for all the people to be involved in the hospitals. And the director of health suggested a hall in his office, so all the doctors to go there to arrange a meeting, and some microbiologists to be there from here in that meeting. And then one of the doctors said, "Oh, doctor, please don't do it here. If you do it here, no one would come here. Can you do it in a big hotel?" This is how it is. You know, I've got no authority on them. The doctors, they make mistakes, and no one is there to say it is wrong. Or there is no such thing as accountability. There is no GMC. So everything is going in the direction which, and people, they accept it. They see it is normal, you see. The hospitals, the number of the hospitals, it's quite as it was 20 years ago. And the population, for example, in Awliya, maybe Dr. Tsaouchi, maybe the population was about 500,000. There are 2 main hospitals, and still there are 2 main hospitals. And now it's 1.5 million. You see the crowd everywhere. And people don't know where to go. So really, we have to realize what's going on. And recently they produced another new law, because the time in the hospital is from 9 o'clock until 1 o'clock. They say we make it from 1 o'clock until 4 o'clock. They will give them extra money for that 3 hours. But depending on what they are going to do what. If they are surgeons, how many operations they do. If physicians, how many patients they see. In the pathology, how many blood tests they do. And the impression is that, if the surgeon, maybe in the morning from 9 to 1 o'clock, they may do 1 or 2 operations, making himself a bit lazy and slow, and all the operations after 2 o'clock. And some of them, they told me they get about $15,000 a month. And same thing with the pathology people. It is really misused. Instead of saying, okay, we start from 9 o'clock until 5 o'clock, we fix the fixed salary, and that is your salary, you have to do it. They prevented consultants to go to private hospital from 9 o'clock to 1 o'clock, and now they told me they go from 5 o'clock in the morning until 8 o'clock. It is such a misuse, and KRG is doing nothing. And of course, personally, I tried my best with everyone talking to. Please, this is wrong. You don't feel it, but because it comes so slowly, it needs at some stage you have to stop it. Unless there is something there in mind, which I think that's to make the reputation of NHS so bad, people go to private hospitals and creating insurance companies and to run the business. And which is I think it is very difficult to run in Kurdistan with all the poor people, with the farmers, with the villages, how to arrange it, how to do that. I think probably they are thinking about that, how to arrange it. But I hope, the outcome of our meeting will be some pressure on KRG, because my own experience really is mainly with Erbil, to do something with it. For example, another thing, there is the oncology hospital in Erbil, which was done by Dr. Kawa's father-in-law, donated to the government. That oncology is 24 beds. I think at least half of their patients is from the south, because they think it is a Mayo clinic. But you go there, there is no medical cover. There is no X-ray facilities at the hospital. There is another one in Suleymaniye called Hiwa. Again, it's an oncology hospital. In the television, they talk about it. We do this, and this is the best hospital in over Iraq, and there is no such center. But there is no microbiology department. And they say 80% of the people die because of infection. And there is no microbiology at all. Even they don't send samples to another lab. And it goes in this direction for how long? When you have to stop it, I don't know. I hope our meeting, someone will listen to it. And thank you very much.
Yeah, thank you very much. I think that was a good insight from Dr. Firyat Awezi, who goes to the Kurdistan region, from his experiences that he's had in the region. And it's good to highlight these, because the aim of the session is today, we're going to try and propose possible solutions to prevent and stop these type of challenges that are happening, and have a system that's robust, with robust governance and clinical governance with standards, and it's standardized. But I think what's important is, and I'll add this part, this is a problem that's happening in all of Iraq, in all the regions of Iraq. It's not just the Kurdistan region, it's all of Iraq. In fact, it's quite common in the Middle East as well, even the neighboring countries, And it's quite a shame, because I think Iraq was known to have one of the world's best healthcare systems. And I think our aim today is to try and propose solutions to ensure that we have, the healthcare system. I think also another thing to add, from my opinion, is that it's the system that's a problem. So it's not coming from individuals or from institutions, etc. It's the actual system that needs fine-tuning. And I think it's quite important to have this form of positive criticism to ensure that we're able to rectify the system. Because let's face it, I know there are some things that we may not necessarily want to discuss openly, but if you were that patient, or if your relative was that patient, would you want to be treated in any region in Iraq, be it Kurdistan, Baghdad, Basra, Mosul, Najaf, any region? Would you feel confident being treated at this current position, with this current skills and training that's available? But in saying that, it's also important not to write off the professionals that are already in the region. And it's very important to highlight, we do have some of the best medical professionals, some of the best surgeons, some of the best physicians, some of the best general practitioners. And they're doing good work in the region, but it's the system that's a problem. And tonight we will focus on addressing the system based on the three questions that we've got, and we hope that will be good. Next. Medical education. I think if Dr. Samith gives us an idea about medical education, etc., and how it could feed back into the type of situation that currently exists, so that it could be circulated.
First of all, I should thank Laween for inviting me to this great purpose. So the purpose of this meeting is to how to reform the healthcare system which is already there. And there are so many challenges, so you can't change everything. So there should be small things which should be changing. These challenges that you see in Kurdistan or Iraq are not unique. They are in everywhere in the world, especially the countries which are affected by war. This kind of corrupt medical practices can happen everywhere. So there should be some sort of system change to improve the healthcare for the betterment of people.
Well-trained and who are excellent doctors who don't want.
Talking about my specialty, which is nephrological, so there are, apart from very few countries in the world, the care of the people with kidney disease are very poor everywhere else in the world, because basically this is a very expensive specialty. You can't provide very, very expensive care in developing countries without compromising some of the basic care that you need to improve. For instance, reducing maternal mortality or reducing care for people who smoke or obese people. So you need to take priorities into the account. So priority is to improve the general health of the country by investing on the primary health care rather than considering very expensive care for few people like liver transplantation, kidney transplantation, that kind of thing are quite good. But the money that you have to spend on that kind of procedure is huge compared to how you can improve the healthcare of a lot of people by spending that money on society as a whole. So how do we improve this? So by talking to Dr. Kawa initially, I got a lot of insight how the system works, and it's all not negative. Dr. Kawa, and I think there's willingness in the society to change. And also, I gather Kurdistan is a very young population, so people would want to change. That is a very positive thing to hear. So how to change it? And there are a lot of things that you can change in Iraq and Kurdistan, especially in Kurdistan territory there, because easy to deliver, I suppose, because Iraq is difficult to access. My idea is to start from medical education, because the doctors who are in training need to change rather than doctors who are already practicing. When the doctors who are practicing getting used to make a lot of money out of the various practices, they don't want to change. This is true even in this country or even in America. So when people start using various corrupt practices to make money, they don't want to change. In fact, they have various ways to keep the system going. Right? For instance, this country, you have a waiting list. So only way people can jump the waiting list is by going to private sector. There are some similar kind of things happening here. So it's not unique to one part of the world. So how to reform medical education? I think there should be a lot of thinking behind how to get young doctors involved in changing their behavior and trying to do ethical kind of medical practice. And the second thing I want to think about is think about something like a general medical council, so completely independent medical body who could keep an eye on the doctor's behavior. So in here, the doctors are very well regulated because they have to practice according to some set guidelines, according to ethical practice, and if something is not practiced in a proper way, that the patient themselves can complain, and that can be investigated, and the corrupt doctors can be held to account. So the first thing I think you should think about is some sort of non-governmental organization which can do a job like a general medical council here. And also you shouldn't forget, you have to use their local people. The people who are providing these things in the ground are local doctors, local nurses, and otherwise, if the local people are not agreeing to any of these changes, and nothing will work. So you need to get the local doctors and local nurses and local politicians involved in any kind of change. Because if you try to dictate terms from one of the conferences here, I don't think anybody wants to take it. One of the major problems in any developing countries is migration. because the doctors who are well trained and who are excellent doctors who don't want to be there because of the threat to their lives and threat to their families. So retaining the workforce is very, very important. So there should be systems in place. They should be well paid if they're in the government sector, and sometimes you can think about giving them extra money not to do private practice. That's what some other countries do, because if you pay well for not doing private practice, then they will be working hard in the NHS system. Similarly, you should get good nurses training. You should make a link with the doctors training with countries like UK, and I think that's already happening. So that's very good thing. Well, I think also Laween is thinking about training on good medical care or good clinical practice. So course in GCP, which are the sort of things that we can help from here. I don't have much to add. I think my message is sort of think about how to change a few things like the system, so that can be used to improve the whole system rather than addressing one or two small issues. Thank you.
Sorry, I'll just add to that. So, Dr. Samit, when you say, adding to the system, which you quite rightly said, one of the things which was highlighted, I think, and it's very important, is that it seems that there's a crossover between culture and ethics, and they're two separate things. And migration is one of them, so that influences the culture that we have in Iraq and its Kurdistan region. One of the things that was identified, just because we're touching on ethics, and just to give the people the context, and as most of you know, I think from what I saw was in consultations, that there were clinics whereby, a doctor would see 5 to 6 patients at the same time, be it private or public. However, on that note, that shows there isn't a lack of regulation, there isn't a lack of standardized regulation in the region. How do you think, Dr. Samit, that could change? What could we implement that we have in the UK? What type of, system, when you say changing the system, just so we get more clarity? Sorry, I don't mean to put you on the hot seat.
Yeah, but there's no easy solution to any of these, because when a system is financially driven, for instance, if you see more people, you get more money. To say that you have to deliver a patient-centered delivery of care, so that is how the change should come. And also there should be a competition. If good care is delivered in a different hospital, people should go there. In medical ethics, the two most important concepts of medical ethics is the patient autonomy and patient consent. Patient autonomy in the sense that the patient should be well educated. If the patient knows what the patient wants, the doctor can't do what they want. And now what's happening in most of the developing countries is the doctor knows best kind of concept. So people don't want to question the doctor. So that has to change. Once that change, there are a lot of things would change. And also, the second thing is about consent. So if anybody wants to do a surgical procedure or any kind of medical treatment, patients should be given informed consent. That means just not signing a form, but give all the pros and cons of a procedure. And it can be sometimes the patient may choose the wrong treatment. That is up to the patient. So educating patients and educating the wider public would be one way to address that.
Thank you very much, and I think that was a very good point he made when he talked about competition, and we'll touch back on that in a second. I think what's involved in changing any system, obviously there'll be a finance element to it as well, and I think Mary would be the best person to touch on that point in how ensuring that funds are spent appropriately and how it could fit into the system, etc.
Yes, thank you first of all to Laween for inviting me along. I'm really overwhelmed by the audience here. Thank you so much for taking time out to listen. I'm a fundraiser, and I've done a lot of fundraising for international as well as domestic organisations, both medical, political and social. And sometimes we have to look at within and think about how we can capitalise on the opportunities by looking at the challenges we have. And so therefore we need to look at the investments people can make in the things that we want to change. And there's a lot of capital investment for people who want to make these fundamental changes to enable them to move on. There's many grant givers, both government and philanthropic, who can help make these changes, but they do need specific outcomes and they do have specific grant conditions to enable that investment to be released. So when I've been listening to the talks, we've talked about ethics, about equality and diversity, and we've talked about the decision making within medical conditions, such as training conditions of work. And we've talked about the working environment, and they're all the building blocks that we can use best practice from perhaps other organisations, or sharing our good practice from Iraqi conditions, and just share and make sure that we're using all the best practices we can to capitalise on the potential investments. So to enable the proper and appropriate valid research to take place in places like Kurdistan and Iraq, we need some basic building blocks to validate that research, to make it legitimate. And then people such as other NGOs and commercial organisations would have the opportunity to invest in the medical conditions that perhaps need a little bit of change within Kurdistan and Iraq. So when you think about the organisations who could support these type of fundamental changes, there's many. There's people like the King's Fund, the Medical Research Council and the Wellcome Foundation. That's just on a domestic level. And they do have international appropriate grant schemes that may be able to help in some shape or form make these big changes. So developing the right framework is part of the building blocks that appears to be coming out of this talk. And that's something that perhaps everyone in the audience needs to think about and challenge themselves into thinking, well, do we want to take this to the next step? Do we want to try and change the ethics and the decision making and the working environments, and hopefully opening up the opportunities to the medical professions within the region? And I hope that kind of sets the building blocks for what could be achieved, and let's see this as not too many challenges and hurdles, but more opportunities for the people to receive better and more practical medical care in the region. But I hope that sets the tone of how we could perhaps move forward and form something, some sort of body foundation where everybody comes together as a non-political organisation and take things to the next level. Does that help slightly?
Yes.
Thank you.
That was an excellent introduction from Mary. I think I'll just go back into the ethics bits, because now the conversation is getting warm, and then we'll try and draw in input from everybody else as well. I think, like Mary said, the concentration should be on developing standardized evidence-based framework for the region that has a clear, robust governance measure which is pinned to the national legislation, and that legislation should be applicable to all regions of Iraq and all regions of the Kurdistan region. I think something that's just come out of what's been said is that there needs to be a system perhaps for regular auditing and quality assurance. And I'm just touching on these terms, and I think the following panel speakers will build on that to provide solutions for these things. I'll just do a scenario, and then if I go back to Dr. Feryal Ahmed or Dr. Feryad, who could expand on that scenario. I'll give you an idea of my experience when I went back to the region, and what I felt, or what shocked me and basically enabled me to want to help back the region to rebuild. Because I was born here, I was raised here, and then I started going back to try and hopefully offer something back with everybody else. I hope it's positive. I went out and with my uncle, who was ill. He had a cold. And we went to just down the road next to regular shops that are selling newsagents, and in that shop next to the shop there was like a small clinic, a nurse that administered penicillin or injecting patients, with penicillins or NSAIDs for simple flu symptoms. And I was actually really shocked, to be honest, because you don't see that walking down the street, seeing all these small clinics offering or administering treatments, particularly if it's not licensed by the Care Quality Commission, etc. And the most interesting thing was when I challenged the nurse that was involved, and I asked some questions. They weren't aware of the permanent, irreversible renal failure, the side effects of the drugs that they were administrating. So it was quite clear there was a lack of continuing professional development in place. And that made me slightly worried and made me slightly think as to how perhaps we could help them. Because it wasn't that they were doing it intentionally. It was that, as Dr. quite rightly said, with time, it just happens. And I think now that we're helping to rebuild that and change that ideology, I think if somebody, one of the panel members, can take over and provide a solution to how perhaps we could stop something like that from happening from a national perspective.
I think there should be there should be legislation to not to sell drugs without prescription, especially the ones with side effects and the ones we know. Antibiotics, the antibiotic resistance there is really, really very high because antibiotics are on the counter and everyone has got a supply in their house. When they get some cold, they say we take a dawra, this is the antibiotic. So I think it should be formalized, legislated, and they shouldn't be sold over the counter.
Just to come to that point, there is already a system that exists, and it is illegal to sell antibiotic in high street. And it's there. It's illegal to sell antibiotic which should be prescribed. I think the issue is not about legislation. There's already legislation, and we have a BNF equivalent in Iraq, in Baghdad, since the 90s. And there's a lot of Iraqi pharmacists. But the problem is monitoring. We don't monitor those people.
There is no monitoring.
The people is happy selling this without any consequences. That's my understanding.
And also I would like to point, even the pharmacists over there, they act as doctors. So they say that well, from what I've seen in the region, that when you go to the pharmacy, you just tell them your symptoms and they tell you, oh, this is a good drug, whether it's prescribed by your doctor or not. They tell you. So in some way they are acting as doctors, whether they have the right to do that or not, I don't know. But some of them, and plus they describe drugs that are, it's illegal to prescribe without the doctor's permission.
I think that's very interesting, because what that highlights is then, I think, could I suggest that an issue that we could put down as a point, as an action point, maybe conflict of interest. So is that what you're suggesting, that there may be a conflict of interest for professionals in the hope of promoting their own services or medicines? Am I right in saying that?
I think that's true.
Yeah. So then, so do we collectively? I mean, I want this to be an interactive session where everybody's involved. Is there a microphone?
Thank you for the
audience?
panel. It's actually, this is a very, very interesting thing, because everybody likes to improve the healthcare, and I think such a panel should be. All the audience knows what you are talking about, but this panel should not be here. They should talk in Kurdistan and Iraq about the defect in the system. Although I don't know how many of you been there when I talked this. I did this talk, and what's happened? The minister was sitting. The old minister was the chair of the talk when I was talking, and the previous minister of the health was opposing, because we done some kinds of talk in order to be interactive, like what you are talking about. And the previous minister was opposing my idea, and all of them was I talked all what you talked about, and the suggestion was that they improve too much, and they have nothing. There is no wrongdoing in Kurdistan, and I think few of you heard what the minister was talking about. He was collecting my points, which is there were no ethics. The medicine will be sold anywhere in Kurdistan, and we talk that there is no system. There is only an outpatient care of the patient, because if a patient is going to the hospital and without, for example, family doctor, without primary care, and you are going just to go to the hospital to have some penicillin or some by any doctor there, by any person, and sometimes by even not a doctor, because I remember on the few talks, few things, that if at the night time, middle of the night, at 2 o'clock, if a patient is coming and the doctor is sleeping in the outpatient, sometimes they are not waking up the doctor. The farrash meaning the worker. The worker is writing down the penicillin and the thing, and the patient is going and collecting the medicine from this place and going back to his home, and is taking his medicine. I think everybody knows, all the audience knows about these things, but they are not responding. They are not agreeing that this is wrong. This point is not wrong. And my friend is asked that medical education, in every lecture in Kurdistan, this medical education is going that the ethics is very important, and we should be very human. We should take the patient's care in the priority. We should be autonomous, and we should consent for everything. But all are reverse happening when he will opening his shop. Why the reverse is happening? He is unable to bring patient by patient to his clinic. 3 patients in one go comes to this room, and there is no confidentiality because he's asking the question in front of another 2 patients, and he is himself that is teaching the ethics, and the university himself he is breaching this confidential thing. This number one, and there is no consent at all, and there is no patient care at all. Because if the doctor is the consultant and the hospital seeing a patient, it tells come back to my clinic, because meaning that I will not give you the proper care now, but later on I will give you this. I think such a panel should be in Kurdistan. Such a panel should be working in a place that there is a listener that doesn't know what's going on. All our audience, I'm sure that they know the difference.
Okay, thank you, Dr. Mustafa. Just 1 second, so that I can answer some of the points that you raised. You did indeed raise some very good points. However, I'm sorry, but I will disagree with you on having only a conference in Kurdistan in Iraq. I just want to make everybody aware there are professionals such as myself that were born in the UK, and some who've never gone back to Kurdistan who want to help the development of Kurdistan and Iraq. However, there's also a vested interest by British companies, by the British government, by various other governments who need to be made aware of the current challenges that are happening in the region. So, for example, an outcome of this panel meeting will go to all the ministries of health, but it will also go to the parliamentary group on the Kurdistan region and the parliamentary group on Iraq, so that they're aware, it's recorded and it's documented. And I think no form of awareness, I mean, the more we raise awareness, the more it can only be a positive thing. And in terms of some of the issues you raised, and I strongly agree with you, which is one of the problems in saying, for example, you gave the talk in Kurdistan many years ago, and indeed you have, and so many others have as well, and they don't listen as well as we want them to listen. But I think perhaps this is a new approach, and we hope that through this approach they might. And in terms of professionals, yes, everybody is more or less aware of the situation, but has everybody given a possible solution? So that's why today I want us to collectively come with a solution for the recommendations. But also another thing, and sorry, and then I'll come to you, is in terms of one of the key problems you highlighted. I think there's a lack of ownership and a lack of, lack of ownership and accountability. People don't feel a sense of ownership, that the professionals that are there, like you said, because when they change, everything goes back to itself. That's why we need to make sure and that the professionals understand there that they are replaceable, but the system is not replaceable, because if there is a system, then, it will run by itself. Another issue is, which I take very seriously, it's funding. I think money that's spent, I mean, it's the same in the UK. Every day I work, every minute, I'm conscious that I'm paid by the taxpayer. It's taxpayers' money. It's the same in Iraq. Yes, okay, it may not be taxed, but the money still belongs to the people of Iraq and to the people of the Kurdistan region. And I think people need to be made more aware of, you know, how that funding is utilized. There is no independent committee or panel that's overseeing the funds that are being spent. That's, what funds are being spent for what hospital? Is it audited? Is there a quality assurance in place? And I think and it's not a negative thing, because they are developing. They've just come out of war. I mean, we have to be realistic as well. And I think this is where we come in, and together we will help and try and build that form of, system.
Yeah, Saman.
Oh, sorry.
First.
He was first and then second.
Yeah,
sorry.
okay.
Yes.
I'm Saran Chowshli, AT surgeon at UCH. We can sit all weekend here and talk about negative points. I think it would be fair to talk about some positive points. Visiting Iraq and Erbil, Islamania, these places, I have seen too many negatives, but quite good few positive things. We don't need to keep talking about negatives. That's one thing. The other thing is, are we trying to improve the system from the top or from the bottom? Yes. In my view, the best thing is to start from the bottom. I think we can recommend to the medical educators in Iraq altogether to try to teach some ethics in the medical school, which I have recommended when I've been there a few times. I don't know if there was any response to it. Whereas he probably knows very well about it. Not only the medical students, the nurses, they need good education and good nursing ethics. If we start from there, I think we can build up very good positive points. Thank you very much.
Thank you.
Thank you.
I think that was a very good point, and you're quite right. There is a lot of good work going on in Kurdistan and Iraq, and there's a lot of good doctors and there's a lot of good local people. It's not that they have a lack of, education or educational standards. They're actually doing very well, and we need to build on that. And that recommendation that you have, if you forward it to us, I'm more than happy to acknowledge you and put it in the report, because it's not our names or anything. In fact, I'll take our names off and put it from the audience who attended today. The point is, we just want to build on what's already been done, on already the good work that is there, and hope that they take it on board. We can't force them, but we can try. We have an ethical and moral duty to let them know of our skills and, express what everybody is saying. But also on the other thing that you said, which was... Yeah, that's fine. Thank you. Sorry. I'm just going to...
Saman Jawdat, anesthetist. I was trained in France and in Germany, and for the time being I'm working here. I used to work in Saudi Arabia as well. I'm mentioning these things just to let you know that I went through different experiences and different systems. I think the problem is in Iraq and in Kurdistan is the corruption, and the corruption, it is on the top of the pyramid. If it is in Iraq or it is in Kurdistan. So if we have really proposal and initiatives and it is not backed, you cannot change a lot. So the main thing really the change to come from top of the pyramid and to go down, and not from the bottom, because there you cannot do anything. And it will take so long time until you change something. Iraq had, before the 1980, the best healthcare system in Middle East. And the reason why, because it was built and set down by the British in early 1930 and 1920. And they continued to do the same system. And actually many of people from the Gulf states and from around, they were coming to Iraq. Corruption, there is corruption in Gulf states as well, but on the top there, and there is no any corruption down there. In Iraq, corruption all over, wherever you go.
And I think this corruption and this bad healthcare system is worse than terrorism. It is a kind of terrorism, really. What is happening with the people of Iraq. In Saudi Arabia, they got General Medical Council, and it is similar to this General Medical Council, which is here. They take everybody to responsibility, all the doctors. They really, they don't,
strict.
Everything is regulated in the GMC there. So if we want to do really something, I know that it is a personal initiative, and thank you for what you have done. It is a great thing, but we have to be really more direct and to see the problem from another view. Whatever we discuss is not going to help if we are not back there. The other thing, I want just to mention something. I know I did see a few people here from the, I think from the Iraqi embassy, but I would like to know who is represented here from the Iraqi embassy, who is represented here from the medical attaché here in London, and who is represented from the KRG representation.
Okay. Yeah.
Actually, they don't care, most of them, what is happening.
Yeah,
So,
no, that's a very good point. I'll address that.
yeah,
If I may.
I think your proposal, it should go to the big offices, big powers.
No,
big aids.
I agree with you, and I'll address
Yeah?
that. In terms of directness, yes, I agree with you. And this form of group, we're planting the seed for reform. I'm not expecting a magic wand and suddenly we get answers. So I definitely agree with you, and I think we need to be more direct and have pressure groups. In terms of corruption, to be honest, that's not a field that I can add on because, you know, yes, corruption exists everywhere, and unfortunately it will always be a problem. Even in the UK there is corruption, which is why they've introduced anti-bribery laws. So it's something that's always going to be there, but we could try and overcome that by perhaps creating a group like ourselves that we are here today and being role models and showing that, you know, we are not involved in that form of environment. It is difficult, but again, this is I think with time it will change. The other thing was, and I agree, and I quite like the idea of where you came from saying bottom up, and then you said top down. And you are both absolutely correct, in my opinion, because if you don't have top support, nothing will happen in bottom, and if you don't have engagement at the bottom, then you don't have any engagement at the top. But in doing that, I think that's where we do a workforce mapping, and you know, we have to map the exercise. But also I think then why don't we be partners? Why don't we all as a group, by all I mean from the bottom and from the top, you know, introduce as an action point, have a form of a committee that links and represents the views, because nothing will change. Change will only happen if there's ownership. How would I feel if somebody came to my department and told me how I should run my department? I will agree whilst they're there, but as soon as they're out the door, I'll continue doing my stuff. But if they came to me and said, hi Laween, this is what we've done, how would you feel if, you know, can we see what you do? And together we reach a compromise. I'll be more likely to change the values of my department. And I think it's a similar thing here. What we would need is an independent panel that's independent from government, but supported by government. And on that panel, there needs to be representation from ethnic minority groups in the region in Iraq, different sects from different villages, you know, a lay person. You know, we need full engagement for a reform strategy to happen. And I think that's what's lacking. And I think if we have that form of group, that would then act as a pressure point on the politicians, on the government, and on the public, then we might see some standards improving. And that's just my opinion. It may not be correct.
Yeah, I think, our duty is really to challenge them and to expose them. We know what they are doing. It is corruption everywhere. You know, and to talk to them really openly, because just in this visit, you know, I saw a few cases of by special fund, they send them abroad for treatment, other people not treated, and mistakes done by some patients. I told them openly, this is the mistake. So really, we have to expose them. We have to tell them this system is wrong, and although you're used to it, but it is wrong.
Can I also just add, sorry, I remembered, I'm not avoiding your question. In terms of representation from, invitations were gone out to everybody. Almost anybody that I can dream of. It was broadcasted on Twitter, Facebook, etc. I cannot force people to come, but people that have a passion will come. In terms of government officials and departments, etc., in terms of KRG, Bayan Sami Abdurrahman, the High Representation, I must say she did support this event and wanted to come to the event. However, she's not in the country. She's returning from Washington today, so which is why she couldn't attend, even though she had attended for today's event.
You could send some representative.
Exactly, they could have somebody.
Right, I can't comment on that. That's not
No, you should comment. This is the problem. This is why they are doing
of course,
it.
you
We have
should
to
defend.
expose them.
You should say they are not here, and it is an office. Maybe they got
should not
50
defend
person
them.
who's working there.
And in terms of the medical attaché,
that is our duty, really.
Yes,
Before doing this, we have to criticize them.
well, that could be put. I mean, on the report, it would be written and who's attending and who's not attending. So, as I said, I can't force people to attend and have the same passion. And it's but.
No, I quite agree with the person because they don't care. Because
They don't care.
They have their own health service. They go abroad for treatment. They don't need local hospitals. They don't need local doctors. So they don't care what happens.
But in terms of the medical attaché, I had also invited her. She was also invited, and I also asked all members if they wanted to submit a statement. So I think that was a very good question. Sorry, you had your hands up for a while.
Thank you.
Can we also try and address questions perhaps to Mary and Summit as well, so they don't feel a bit left out? Because they have come very far away. One's come from Suffolk and one's came from Cambridge. So these are the things where we're lacking.
I came also from far.
Oh, sorry. Sorry.
Anyhow,
and we're very grateful for your presence.
I'm Professor Robert Stepanian. I'm professor in e-health technologies in King's University, London. I just finished led two projects on e-health and mobile health with Iraq, with the medical school in Basra and the medical school in Baghdad. So I would like really to address the issues of how we can implement a strategy for digital health in Iraq, because that's fundamental, very important. What we found as a result of these two projects, one is funded by DFID, Department of Foreign International Development, and the other one by charity CARA. And we did two very simple pilots on using text messaging for educating on diabetes patients. And what we found as an outcome from this, and on the CARA actually we did an intervention, a small pilot of 15 patients where we give them mobile phones and we try to see how they improve their glycemic levels. And we found both that clinically it is very effective in controlling the diabetes, and also patients were very, very keen to use this because everybody has a mobile phone. And so I think the outcome from the Delphi, we put a strategy for digital health for Iraq 2020. It's about a year ago, and I'm happy to send it to anyone who is interested. They were very keen interest from the key people, the deans, the key medical people, the patients were very interested in this technology. In a matter of fact, we were in Amman, one of the patients even sent a text to Dr. Tagreed al-Haidari from Baghdad about gestation diabetes and how, because that was one of part of the studies. So what happened is that they knew that, as the discussion was, there is a corruption and they didn't care. Look at how in UK we are digital health, e-health, electronic patient record, how big it is and how it is fundamental in terms of primary care and secondary care, and this, of course, in the US and most of the developing countries in Europe. However, nothing is followed, except now a very small $20,000 funded project from Baghdad College, Al-Kindi College, to fund a follow-up on the gestation diabetes. $20,000, and they sent me, Dr. Tagreed sent me the email just about 2 months ago, and I'm sending her, Dr. Tagreed, when is it where we are going to start the project, and nothing happened yet. So the key thing, as I'm saying, a fundamental concept like digital health, e-health, which is so important in ICT for healthcare globally, should be now put on the agenda. And the key politicians know about this, and probably they know, but actually there is this disconnect between the Iraqis outside, the clinicians and the experts, like the people here and myself, and of course the politicians in Iraq, how to push the agenda on this. So there should be some sort of an action and agenda to introduce e-health and digital health both in Iraq and in Kurdistan, and urgently, because it's very much needed. And it is the one that is going to provide the leap that we require. For example, we are saying about the medicines. Very simple technologies now there are, where actually you put an RFID on each of the medicines that comes to Iraq. Anyone, and these can be communicated on the computer systems on the hospitals. That will immediately remove all the problems we have with counterfeit drugs and drugs is not delivered. So innovation is fundamental to improving the healthcare, and it's much needed with Iraq. Thank you.
Can I comment on that? I met Professor Stepanian, and he's just one of the brilliant new people I met ever. But there are a few issues here, which I went back and I spoke with the health minister, Dr. Record. There's two major issues. First of all, we don't have any database, so we don't know how many diabetes people are on. So they said, okay, if we're using that system, how going to be very efficient and effective? And the second thing, the people there, because of a lot of corruption, as you mentioned, and we are mentioning here, they are having doubt in everything. So whatever you mention to them, they're going to say, is it really working? Have it worked before? So in my opinion, when I came back from that 2 trips to Kurdistan and to Iraq, in my opinion, we should establish it here and make it work, make it a free trial, free research for them, and then show it to the people. Is it working? We don't have any database. We need to find the database as well first, and then apply any innovation, technology innovation. Otherwise, it's going to be the vicious circle.
No, that's the infrastructure, the ICT infrastructure. Now we don't need a big thing. Now there is a cloud everywhere. You just bring a small computer, put it somewhere in University of Baghdad or in Erbil or whatever, and start. The patient comes in, a nurse takes the measurements by the iPad, and everything is sent to the very simple solution. But the problem is that who is going to be the spearhead this and tell the clinicians, the corrupt politicians, that this can be done, and it is fundamental now everywhere in the developed world.
Can I just add a point and then go to Dr. Mustafa?
Yeah. Oh, yeah.
Oh, go on.
Okay. We proposed this idea. Sorry for Dr. Mariwan. He's supposed to be here within the panel, because me and Mariwan and Sheikh in general, we tried to do a lobby in that conference that we attended. And because the conference was regarding 25 years after the Halabja, so we tried to do a pilot study in Halabja and to implement this digital issue in Halabja, because only there are 35,000 people, and they are deserving to have the change from Halabja, because Halabja is the place in Iraq that affected more than any part of the Iraq destroyed by previous regime. So we thought that only maybe needs few clinics for primary care and with the computer, things like that. And because we talked previously also, me and Dr. Friat, because we know that the main thing is the politician should act on this act of the health in order to have the change. Because only the politician, either Maliki or Barzani or Talabani, one of these people can do the change. None of the other people. If 10 ministers will sit down here, or 15 of the parliament people sitting now in this panel, they have no any effect. They can't do any change. But because this is the strategy of the country, because this is something the politicians should do that. But because this is not the priority number one. For Baghdad, because of the security issues, the priority number one. They don't care for the health. And for Kurdistan, there are other priorities before the health. So they will not touch the health now. They will not do the change. So we tried to do this digital thing in 35,000 population city, but they refused that.
But we have done it with the government funding from the UK. And when we said, right, let's do a larger thing now, started with Iraq, of course everything is shut up. But there is a problem we found. There is a conflict between the Ministry of Higher Education, I'm talking about Iraq, not the Kurdistan because of my direct experience. There was a conflict about who is going to lead this. Is it the Ministry of Higher Education in Iraq, or is it the Ministry of Health? So there was a problem because anyhow, anything you lead should be led by the clinicians in the medical schools. And they, one of them, they said, actually, Minister of Higher Education has no money or something like that. One of them have no mizaniya, budget. But so it's bizarre. I mean, how can Ministry of Higher Education doesn't have
budget?
I think just if I may to add to that one, because that's a very good example what you did. I think your colleague is Nada Phil.
Yes,
one of my lecturers as well in bioinformatics. She
apologized. She couldn't come.
No, that's fine. This is excellent as well. So thank you for being here. In terms of what you've just said is absolutely excellent. And in terms of the data set, I just wanted to touch on that. I think what's also happening is in different regions, they're trying to compete with one another as well. So for example, in the Duhok region, they have they've got like a pilot electronic medical record system, and in Holer as well, and some parts are falling apart, and now Slimani's got it as well, but it's not up to speed. The challenge that I identified, that I feel is a challenge, I think is lack of understanding the systems. I think the policymakers who are making the policy decisions on the reform strategy don't necessarily know the benefits, pro and plus, of a computing, and that comes down to the culture, I think. And I think through these type of conversations we could change that. For example, if you go to Iraq, maybe a couple of years ago, certainly when I went to the Kurdistan region, that's my experience. When I first told them about, the idea of having an electronic medical record, some people actually laughed, as in they found it funny. They were like, what's you on about? We don't have time for all of these type of things. But now slowly, with the world changing, they're starting to realize that actually, yeah, this is one of the pillars of it. And I think your report would be absolutely excellent. And I think that's why I think that it's so important to have these type of events also in European countries and around the world, but involving local members of parliament, i.e., which is why this report will go to the local member of parliament, so that at least they could raise this with the politicians and the policymaker, because we don't have, that type of access and that type of ability to do so. And it's quite sad, because what's sad is, as healthcare professionals here, everybody has a skill that they can offer. So I mean, I'm not the decision maker and say, yes, that's an excellent idea, let's implement it. But what I can do is say, yes, let's raise awareness and let's try and present it. Or, I mean, otherwise...
I think the key thing is to make a workshop, invite the key deans of the medical schools, both from Kurdistan and which I know 2 or 3 of them at least in Iraq, that they are very, very keen to implement this strategy. And then, because they are anyhow deans and presidents, maybe 1 or 2 presidents they will then force the politicians.
Now that's an excellent idea, and we could add that as a recommendation and as an action point, and we'll campaign for that. But if we didn't have this discussion, we wouldn't have been able to get that excellent idea that you provided. That's why I'm grateful for all these ideas, because I will document it and we will present it.
Well, but I think...
Sorry, the key thing is not documentation, it's the action. The problem is how we can penetrate this corrupt system and make things happen in Iraq to improve the healthcare of the people. The problem is that you document, you put things even on the level of the deans and maybe presidents of the university, which are actually appointed by Maliki himself. They come and they cannot make a decision.
Can I say something? A comment on this. I don't think they're gonna do something because they are part of this corrupt system. If you are going to ask them to do something, to improve something, it wouldn't be, because it will touch their interest.
No. The big. Are you talking about the big clinicians?
Yeah.
No.
Even
sorry,
these.
they are clinicians.
What I am suggesting,
but
it is
they
really
are
for
hit
you.
by the stone of the politicians. You have to differentiate. Sorry, I have a direct experience with them. The clinicians are very keen, and actually they say they are the politicians who are standing against any movement into improving the healthcare of Iraq.
So I think, just if I can add something as well, please. Sorry, just if I may. In terms of when I say documentation, and I think this is where we're not perhaps where we need to think. I mean documentation at the right level. I mean, for example, through dialogue documentation by 2 local parliaments in, for example, the UK, for them to then pick up these bullet points and raise it with the politicians in Iraq. And then the Iraq government is more likely to be receptive to getting recommendations. Because we have to remember, for example, let's focus on the UK. UK has an interest in developing its trade and investment in Iraq and Kurdistan region. They want things happen. I'm an advocate for British companies, British universities, British skills and experience to go to Iraq and Kurdistan because it's a system that I trust and I'm familiar with. And that's what I meant by documentation. We can't just go in there, I think, and just empty-handed. I think it needs to be documented in the right place, the right government institutions, and then it will be taken seriously. But
I want to suggest really something which is maybe going to improve the system. What we want to do to defend the patient, exactly to defend the patient, and to have somebody to defend him, an organization or a body. Because we don't have it in Iraq and we don't have it in Kurdistan, and really it is a problem because of the politicians and because of the doctors themselves. The only way is to use the media and to go to the patients. Which patient had problems with which doctor, and bring them on the media, talk about the doctor himself, and you will see if they will not be scared of the media and of their practice as well. So we know that there is GMC behind us. We don't do mistakes. We are very kind with the patients. We do whatever which is helping the patient and make him happy. But in Iraq, it's other way around. Yeah. It is a suggestion to use the media, and to.
I think that's an excellent idea, and I'm really glad we're now moving towards solutions. And I think just to build on what you just said, it must be patient-centered. We must have our solutions based around the patient. And one example that you quite rightly gave, and I gave an example of this a couple of years ago, and I said, for example, we get British doctors. There are some doctors that go back to the region because, let's face it, the business is thriving, especially in the medical healthcare sector. They'll open a clinic, they'll see perhaps 5-6 patients at a time. They've got their GMC and UK, qualifications on the board, okay? But they won't follow the same ethics that they would have followed if they were in the UK. So do the patients in Kurdistan know, or in Iraq, that they can call the GMC and report that doctor to the GMC? No, they don't. And I think that's probably one of the most important action points as well, of having a strong recognition of a patient pressure group. And that's something that I would also put in the report. It's just some little things like that. I'm going to go to my other two speakers, Mary and Samith, because I've noticed they've gone very quiet. So if the questions could be.
I think because we diagnosed a problem like
yes, so let's agree the treatment plan.
Smith and Ms. Mary Atkins to propose any treatments or solutions for this matter.
I'm just really pleased that somebody's mentioned DFID, because you've all made some really legitimate points, but I'm sorry to say that you do need money to find a solution to these problems, and you need to present the case for support in a constructive way that people can help find a solution. And funders like DFID and other international funders can perhaps contribute towards the cost of finding these patient-centred solutions. And I'm sorry I have to talk about money, because money is primarily important to try and find these solutions. So if we can come to an agreement, the room can come to an agreement that you want a patient-centred health service, then this could be built up into a case for support to take to all sorts of different types of international funders to look for them to help and find case studies from throughout the world or throughout Europe to take and share with the Kurdistan or Iraqi people, and then the governments of both countries would ultimately have to make some sort of gesture or support to be able to get this inward investment. And I'm really sorry to talk about money, because it's a very difficult subject to bring into such a passionate debate, but you do need money and you do need a solution, and you have to present a very strong case for support.
This is a very interesting point. The DFID project that I led and funded with Iraq, it's about actually first introducing e-health services to Iraq. And matter of fact, there are now supposed to be 2 e-health centers, one in medical school in Basra, the other one in Al-Kindi Medical School in Baghdad. The funding was about £90,000. You know, the follow-up to the project from Iraq, we thought, right, the British put 100,000, so at least they would put £500,000. they funded $20,000 project.
I think there is.
So this is the statement about the knowledge about the politicians. And this is a project that called innovation projects from the health related to from the Minister of Higher Education in Iraq. And still, after 3 months of being with all these stamps and signatures, the old time, signatures and million of stamps, because they send me the letter. So that tells you the lack of the in-depth knowledge of the politicians sitting there.
Yeah,
awareness, and the awareness doesn't come from the Iraqis, should come from the Iraqis working with the Iraqis, the Iraqis from, in the UK, abroad, working with the Iraqis, the honest Iraqis, in the clinicians in Iraq and Kurdistan. That want to make a change.
Regarding the money, I think there is money, but it's being invested in the wrong places.
Yeah.
Iraq is a very rich country, but I think politicians are being invested, the money is being invested in the wrong direction. Maybe we can redirect this into the healthcare profession and propose solutions.
No, I think there's an important issue which the speaker said, which the previous speaker said that health is not on their agenda. Probably how can health is not a priority on their agenda? How can you build a nation if now we have a prevalence probably 10% in Iraq on diabetes only? Half of Iraqis are either diabetic or hypertensive or problem with the cardiovascular diseases and the cancer. So if this is killing the Iraqis.
Talking about the money again, if the money is not for improvement, they have got plenty of money. When it is for some change, for improvement, there is no money. I've got a good example. Last time with Dr. Mustafa, we were in a conference. They spent, we are about 400 people. They spent all the accommodation, hotel, fantastic dinners. They didn't let us spend a penny. But just a month ago, I asked them that 2 British doctors from the Royal College of Pathologists, they go to Erbil for training the trainers. They said, you have got no money for the tickets. And coming back to the computerized, again, we tried a lot to computerize, especially the labs in Erbil. And because no politician has got his own company, they say we don't need it.
Well, there is an important issue actually. Whatever happens, any initiative, I call it digital health, by the way, this old-fashioned computerized thing. We are living in the age of the smartphones and iPads, so this computerized thing is an old 20th century. It's digital health, e-health, and m-health, and the scientists who coined the term mobile health. Anyhow, there is an important thing in which the clinicians, because of they have to also get involved into any initiative like this. The clinicians themselves, because now I notice also some of the experiences the clinicians now, they are they are looking also after their how much I can gain financially from this.
Yes.
So that's also an element which we should consider it. Because now most of the clinicians and the doctors have their own private clinics, and they say, why do I need about to do e-health and things like that? I'm earning $10,000 per day for my private clinic. So that's something that will entice them also to include them in that process. So it's a complex process, but it's
I want to ask a question.
I think, there's just 2 more questions, and then we'll go on to the research side, I think.
I just want to ask the question and just answer that gentleman. I don't think we should scare the clinicians by publicizing in the media, because that's not productive and that's not healthy, because you don't want to break the relationship between patients and the doctors. You don't want to break down that relationship, because otherwise
could you defend them?
There is a trust. People trust doctors to treat them, and if you break that trust, then it is very difficult to put it back together again. So we're trying to build a relationship, strengthen that relationship between the public and the profession. And that's one thing. The second thing is I want to emphasize this, and I want to say is the patients, who's in the best interest of the patients? Is it the doctors who are in the best interest of the patients, or acting in the best interest of the patient, or who else? So in my mind, actually, my experience is based in the UK. In my mind, BMA looks after doctors. GLC looks after everybody, including patients. But the best thing, some things doesn't cost money. Educating nurses. Nurses are in hospitals, NHS hospitals, they are patient advocates. they can stop the doctors, they can stand up for the patients to say this particular treatment is wrong, and they can stop it. They can highlight it, they can bring out that this is an issue. They acting in the best interest of the patient. So if you empower nurses, for example, they can act in the best interest. If you empower people to act in the best interest of patients, then a pharmacist shouldn't sell over-the-counter medicine to a patient, or causing harm to the patient. That's the best thing. Some of us say, yeah, it costs money, of course, but what we're talking about is a massive project. The infrastructure doesn't exist. There is no system in place to remedy by a simple just pouring money in. Digital health doesn't work in Iraq in such a system because there is no foundation for electronic system to keeping patients' record. There is no patient record kept centrally somewhere. Everybody is on temporary basis. One patient goes to the doctor, he puts a couple of lines on a piece of paper, and that's it. There is no patient records. So the basic thing is we need to do is start by educating. It starts from medical schools. We have to build these from bottom up, but at the same time help from the top, and the professions should take ownership. The medical profession should take ownership, in my mind, because they are the people who knows what works, what doesn't work. And if they don't work, if they don't act in the best interest of the patient, they should form like BMA. They should implement a system of license. If somebody doing wrong, they should take the license away from them. They cannot practice anymore. Without going to the media or highlighting on television who did wrong. But these people can be the profession themselves can monitor themselves. They can act in the best interest of patients rather than actually just demoralizing doctors. We need the doctors. We need their enthusiasm. We need their support. We need to bring them to the front rather than actually alienate them.
Actually, I agree with you. What you are saying is correct. But if 99% of the doctors, they are really correct with the patients and they do their work not like a business, like a medicine, that is correct. But if the thing is other way around, you cannot really do it. And there is no anybody who is defending the patient, then they do whatever they want. And the majority, they are really doing a business and not doing a medicine. You can add them. They went there many times and they worked in the hospitals and they know how it is.
Yeah, thank you. I think that was very good. I think it's also important, just to add on that there needs to be a mechanism in place, and I have strong feelings about this, that other people should also be involved. So, for example, also the younger generation, because the younger generation, when they go back to Iraq and Kurdistan, they're automatically disregarded. There are people that all around Europe, particularly around Sweden, Denmark, because of the 80s, 90s, the war, that have grown up and born in other countries. And I think we need to have a mechanism where their idea is also put into the reform strategy. And for me, that's very important, and I think I just wanted to add that bit.
Can I ask a question?
Yes, please.
I just want to know what happened about private hospitals. For example, are there German hospitals, other national hospitals, and what sort of regulation they carry out, and why don't we use them as an example to improve Iraqi hospitals?
I totally agree, and what I think is at the moment, there are different hospitals like German, etc., but it is not. It's based more from the architectural design. In terms of monitoring and treatment, it's not the same as the respective country. So, because we're in the UK, I'll use the NHS as an example. No?
There are hospitals, they're called German hospital or Jordanian hospital, okay, or Turkish hospital, but they are run by Iraqis. One of the doctors was in Germany and he opened the hospital there, he called it German hospital. Oh. But there are people, they bring them, say, from Germany or from Denmark or from Lebanon for a few days, or from Jordan to do operations for a few days, and they give them a lot of money. They stay for 3-4 days, they do operation, and they go back. There's no teaching, scientifically, no one got any benefit from it.
They are not
They come for
responsible on
money.
the complication.
They come for the money, and what happened to the patient later, they don't care. And that only name is Germany or Jordanian or Turkish. That name is misleading people.
But just to add to that, I think so. For example, if for the purpose of a pilot study we implemented, for example, like the NHS. Now, let's be realistic. The NHS isn't great either. There are weaknesses and there are strengths. So if we implemented the strengths, if it's relevant to that region, that would be wise, you know. But even I think if it's run by those professionals from the country, like by the locals, Iraqi or Kurdish, I think it's fine, providing that they've got the specialist training. So why should we have a German or British hospital in Kurdistan that's run by British people or just German people forever? It's good for a pilot, I think, as to start off with, but train-the-trainer basis. I don't think that we should be dependent on other nations. You know, I mean, we weren't like that before, and I'm quite patriotic and, you know, want that to continue.
I'm sorry, I'm referring to the standards and regulation and the accountability. So there should be a system whereby the patients will be protected if there are complications.
Currently there's no system like that.
There should, but there is no.
So how we start that? I mean, is it possible to start, for example, with the politicians' involvement, like having a hospital with shares, and doctors can have shares in it, the nurses can have shares, and the politician a bit of share, and the patients they have shares as well. And started as a model.
I think that's a good idea, but that's quite dangerous. What I would suggest to build on that idea, I would think we should pick a poor hospital in the region of Iraq, in Kurdistan region, because it's safe to travel to as a pilot. I think we should then implement those, you know, standards in the most weakest hospital there is. And when that hospital is improved, that will automatically create a competitive nature within the other hospitals in the region and in Iraq, and that philosophy could be rolled over. Then you'll have a system of quality and star rating, so you have that system in place. Then it could be measured by, you know, an independent panel or an independent committee like the Care Quality Commission, MHRA, and all the relevant regulatory things. Let's face it, we all have a competition, you know, in us. We all want to compete. Surgeons compete with one another, nurses compete, etc. The best way to do it is to implement one of the best, and let's focus on a department. Why the hospital? Let's focus maybe on hematology, pathology, which I know they're doing great work on, bioinformatics, you know, telehealth. Let's focus on that niche and make it the best in that hospital. Publicize it in the right channels, i.e. through these type of events, to the relevant ministries and parliamentary groups around the world. That would raise awareness, and then I think the government might be more receptive. It's an idea. It may fail, but then we won't know until we try that. Has anybody done that yet? Have we had a department that's been fully managed to an international standard for a long period? I mean, I don't know. Has that, you know?
But you can't have a department unless you change the system, the whole system.
It's an example. Yeah, but if you stick with one hospital, then and test it, then that's how you'll be able to. What's the gold standard? At the moment, we don't have a gold standard in Iraq. And to have a gold standard for the purposes of auditing, you know, we need to start somewhere. Or we'll just go around in circles, and that's, you know.
Yeah, regarding, well, I believe the standards and regulations, whatever we have been discussed, if there are not initiated by the decision makers, it's good, I mean, to patient awareness or doctor awareness, etc. But we are a nation, we are not implying regulations and norms, even in ethics, unless we are afraid of punishment. So what I think the government should imply, put strict regulations and imply it. Otherwise, like other sects, for example, Marur, traffic, for example. People, there are zebra crossings, but no car would care about pedestrians, unless there are some penalties, restrictions, and firm implementation. Otherwise,
deal a lot with international relations,
I recruit a lot of patients from the Gulf, and we started already a program called a Visiting Doctors Program, where we take some doctors from the UK in the high ranks and send them to the Gulf to try to implement all the legislation we're talking about. We're talking about quality control, we're talking about clinical competencies, we're talking about research and development. I try to implement Iraq and Kurdistan to our program. Two problems we face. As you mentioned yourself, safety, one big important aspect. And this is where we have to find a pilot, a safe place for my staff, my team to come to Iraq, Kurdistan to try to develop and set the standards. Another issue, as Marianne and your honorable guests have said, is finance. This is another big issue. I actually had a meeting with one of the senior ministers of Kurdistan who came to our office, and I proposed a plan. Big issue, no finance. So it's a huge problem. We are ready in London to try to provide support for your plans and your project. So please take that into account.
No, definitely. And you see, and I'm sorry, and I keep going back to the purpose of documentation, is because once this is documented, what everybody's saying here, that would be in a public domain, and only then we could go and, you know, propose solutions, and we have the evidence. It needs to be an evidence-based framework. You know, that's the type of framework that we need to work towards. And I think I'll ask Dr. Abdi as well, who's been quite quiet, to also give some contributions. And then we'll move on to clinical research. Very briefly.
I'm glad this gentleman. I'm glad this gentleman mentioned the point of safety, doctor safety. I'm not sure whether it's been mentioned before. I think if you're submitting an outcome of this meeting to the Iraqi officials, I think doctor safety should be also mentioned in this report, because they are targeted in a very bad way, and this should be really reiterated as a very important point stressed on.
Can you expand on that? What do you mean they're targeted in a bad way?
Well,
the doctors are targeted, or the patients?
Terrorist attacks. You know, doctors are killed, kidnapped. Possibly that doesn't apply to Kurdistan, but that definitely applies to the rest of Iraq.
I agree with you, and I think security is a risk, but then that's more of a national security issue. And I think we can record that, but you know, that's part of the national security development. But at the moment, the Kurdistan region security is slightly better. It's still at risk of terrorism, but it's slightly better than the federal Iraq, which is why we're saying, shall we use that as a pilot study and roll it over to Baghdad? I mean, it's. But that is an issue that obviously is very serious, because that may prevent, you know, the rest of Iraq from moving forward, which shouldn't happen at all, and which is why we need to have a harmonized effort so that both sides receive the same best possible care available.
I'm not only talking about the general bombings that happen all over the country.
Okay.
I'm talking about targeted doctors by kidnapping and you know, shooting them, and just doctors are
Okay.
And if this is documented and stressed to the Iraqi government,
Okay.
You know,
No, that's sorry, I wasn't aware of that. I mean, I'm not aware of everything. You've got my email address. If you send me like articles and the evidence of that, I by all means will put it in the report. As long as it's evidence based, it's not a problem.
It is definitely, yeah. I'll send you something.
Yeah. I think Laween has enough information to put in the report by now.
Yes.
I think the topic of the meeting was how to use ethics to improve the delivery of the medical services in Iraq and Kurdistan. I suppose you need to stick to that topic, because you can't change a lot of it by a pressure group. So it's a good idea to pressurize the politicians, but you have to take the local people into account, especially local doctors, and you can't work against local doctors. You have to, at the end of the day, they are the ones who are going to deliver the care. So you can't. There are good things that you can develop them. Unfortunately, it looks like the undergraduate education is good, but once they become doctors, they change the practice. So suppose you need to concentrate on postgraduate education, and what's happening in UK is something like revalidation. Their practice is monitored. That kind of thing is important. So because there's so much to talk about, I think I'll
I'm wary of time, so I'm going to just very briefly talk about clinical research and why I think that's another element. Just wrap it up in a couple of minutes, and then we've got a really excellent person who's come from Manchester who will just give a 2-3 minute synopsis of what he does, who works in NIHR and has a lot of experience with pharmaceutical companies. So my role is, I'm chief of R&D. I'm in charge of an R&D department in Essex, and we're one of the world's best burns and plastics hospitals. And I have that vision for Iraq as well, Iraq and its Kurdistan region. And I think that will bring a lot of benefits to the region because A, it will enable patients to have access to cutting-edge clinical trials. I think it will advance the body of knowledge. And also I think in terms of publications, so there's clinical research, it's very broad and it should have a session in its own right, so I don't want to go into detail. But I just want to touch on some of the foundations which I think we need to note for the purpose of this conversation. In terms of clinical research, I think we need to have a proper structure in place. We need to have a structure for funding, because Mary will quite rightly say, and she supported a lot of our researchers, funding doesn't come easy. And in terms of having, in terms of different clinical trials, different specialties, because that itself will fall into the improving of the healthcare system. But it's also important to note, which is why I cheekily added it into this conference, is research ethics is quite different from medical ethics, and we're getting a lot of outputs from Iraq and the Kurdistan region saying, let's do research, let's do research. And the reason I added it was, yes, we will do research and we need to build on it, but first let's focus on the basic medical ethics, and then we'll go on to the research and research ethics, and that will come in education and training, like you quite rightly said, good clinical practice training. So let's get the research right by basically offer the training first of research ethics before we even think about doing clinical trials, based on the output and the experiences that we're getting from different panel members and different members of the audience today. And I think everybody will also have a different opinion, and that's one of the positive things about this event. Some people would have had a positive experience to the Iraq and Kurdish healthcare reform, and some people would have a negative, and it's about harmonizing that experience. I don't want to go on further. I think you've heard my voice too much today. So, Joanne, kindly, if you want to just introduce
another guest to us today. His name is Mr. Azad Aziz. He's worked for 11 years for AstraZeneca Pharmaceutical as a senior scientist in research and development, and then 5 years with the University of Leeds Medical School at Experimental Mycology and NIHR, which has been set up by the Department of Health to support the research in the UK. And if you could kindly give us his opinion about this research. Thank you.
Thank you for that introduction, and thank you, Larry, for inviting me here to talk about my experience. My experience is based at UK. Was based at NIHR, National Institute for Health Research, which is funded by the Department of Health. What I'm talking about today is from my personal experience. It's not on behalf of NIHR. Is research possible in Kurdistan or in Iraq? At the moment, the standard of research in this country is very well founded. It's very tightly regulated, and it has got its own principle. It is still, there are concerns even about UK, doing research in UK. A lot of international companies like AstraZeneca or GSK, Pfizer and Roche, they invest a lot of money in research, in medical trials, in clinical trials. And the government itself spends a lot of money on supporting clinical trials, either investigator-led trials or commercial trials. Either way, there are some foundation and some principles that clinical trials have to meet before they can start doing, before they can recruit patients. And I'm very glad for the professor who brought in the topic of discussion of using a clinical trial as a model to improving the system of healthcare in Iraq or in Kurdistan, because it is possible. It is possible to use medical research to improve health, because patients advocacy for patients and patients' best interest is served here in UK by the ethics committee, by MHRA, where they can evaluate the clinical trials and look at the protocols, look at the study design to make sure the study conforms with the standard of care. We all know that in UK, prescriptions are regulated by NICE, and lines of treatment are regulated, very well regulated and very well documented. So we have got a documentation system. So for clinical research, you need those documentation systems to be existing. Building a medical ethics committee is probably the #1 priority for improving the healthcare in Iraq and in Kurdistan, because they can act on behalf of the patient and safeguarding the patient's best interest. But who can build on that is the medical profession themselves can build that ethics committee, for example, in Kurdistan or in Iraq. At the same time, I want to just say, clinical research in the UK, they have to conform to some criteria set by the Department of Health. For example, not every clinical research will succeed into NHS and they can use NHS patients. They have to have a research question. They have to have been reviewed, peer reviewed. So for clinical research and clinical research in Kurdistan, they need to have a committee of specialists. So another priority is to build on a network of specialists and to build on the trust of the specialists to come together, to build a committee, to build a panel of experts to evaluate the healthcare, evaluate the patient's care, and evaluate standards. So we need to build those infrastructures first, and then we can start off by building clinical research in a small area and rolling out to a bigger area. And that probably works in the best interest of patients. We can't change a lot of things in Iraq and Kurdistan because of those problems you have already discussed here. And thanks very much.
Thank you very much. Thank you very much. In the interests of time, I think it's best we summarize and close. And sorry because it was meant to finish at 6 and we did start half an hour later. I'm gonna finish on. We received a lot of comments and possible solutions from a lot of doctors, especially in Iraq and in Kurdistan. A doctor that probably most of you know is Dr. Ghazi Zibari, who's a professor of surgery, and he's involved in a lot of work in Iraq and in Kurdistan. And he sent me a private message, and he gave about 10 strengths and 10 weaknesses, but I've picked about 3 of them, which I think we'll finish on because it more or less touched on what everybody else said. In terms of the strength, it is felt that there's a good healthcare manpower, there's good financial support from the government, and they've been able to establish relationship with outside medical communities. However, the weakness is that the public has lost confidence on the present health system, and this needs to be addressed, and we need to regain public confidence at all costs. And I think also another thing was we need to have state-of-the-art level 1 trauma centres which need to be established as soon as possible. Too many younger ones get killed on the highways every day, and the medical community needs to address this issue more aggressively. And I think he's right, because I've been in the riots in the region. It's very dangerous. Another thing is he feels, and we all feel, that you must send the young and bright students abroad to obtain higher education, subspecialise, and it's also time to decentralise the health system. Allow doctors to work in the hospital in the afternoon and night, and should keep a fraction of what they've generated, get them stimulated. So basically he's talking about continuing professional development programs, let's invest in the education and training. And I think that's all for me. Is there any other things that we want to close on? No? Is that okay? Thank you ever so much, all of you, for coming. All your presence is greatly appreciated. All your support is appreciated. I assure you that we will write every point that was raised. I mean, be it negative, be it positive, it's all different opinions, and there's no harm in that opinion being portrayed to the relevant authorities. So we will record everything, and and thank you very much, Kakaziz, for coming and presenting. And email me things that we could do to improve as well. I'm happy to work with anybody. All right. Thank you.
That's a good start.